Willkommen zum Triage Method podcast with me, Gary McGowan, and my co-host, Mr. Patrick Farrell. Paddy, how are you this week? Wie geht's?
Guten Morgen. I am absolutely fantastic, Gary, as per usual, because the world is fucking great. We are still locked down. We are still under house arrest. But look, it's fucking sunny out, and that's the main thing in this world. Once the sun is out, happiness abode. But anyway, Gary, let's not talk about our lives. People don't need to hear about it. They're bored enough with these podcasts as is. So what are we talking about today? Like, what is the topic of conversation?
We're talking about the pharmacological and surgical management of obesity, i.e., what drugs and surgical interventions might be of use for people with obesity. And again, the reason we're touching on this is not because we want to give medical or surgical advice. Very clearly, this is not the place for that. But we just wanted to round out the discussion that we've been having for many, many months about obesity, because we've touched on the role of nutrition, we've touched on the role of exercise, we've touched on all the pathophysiology of obesity, everything that contributes to it. And this is really the final pillar. And the reason it's important to discuss, I guess, is because I guess weight loss pills, weight loss drugs generally get a bad rap. And I think for good reason, because many of them have failed or have led to more adverse effects than beneficial effects over the years. And I guess if you come from the fitness industry, you probably, have some sort of stigma associated with or directed towards weight loss pills generally, because when you think about supplements, for example, that are advertised for weight loss, the vast majority, 99%, do absolutely nothing. Okay. But there are some drugs, pharmaceutical interventions that actually can be helpful for people with obesity. And it would be a shame to allow that kind of stigma directed towards supplements to override a potentially useful intervention for these people. So, first things first, I think that one of the things we wanted to mention briefly was the fact that all of this still comes back to the discussion of energy balance. And I think that this is also one of the things that one of the reasons we wanted to discuss pharmacology is because despite the fact that you're using drugs in, super physiological doses, it still all acts through that calories in, calories out. The vast majority of the drugs that we will be discussing will do effectively one of three things. Okay, they'll either increase energy expenditure, and most of them don't really do that. They'll decrease appetite, okay, or increase fullness or satiety in response to food, or they will reduce the absorption intestinal tract. So all of these things you can see are either increasing calories out or decreasing calories in. So it's again, it all comes back to that very, very basic equation. But as we know, and as we've discussed in this series as a whole, there are many other things that tie in with calories in, calories out. So just keep that in mind as we head into this conversation.
Yeah, and I just want to put this out before we start this podcast that I am most definitely an idiot. Gary, for sure, is an idiot. So
absolutely,
I would not be taking this as medical advice, just straight up. Like the two of us are actual idiots.
okay.
However, we are both interested in this stuff. I like the fucking biochemistry stuff. Gary, I don't know what he likes. He's a bit fucking weird. But he apparently likes this stuff as well. And I think this is a good lesson in terms of reinforcing that calories in, calories out perspective. But also I think it is a good lesson in terms of realizing that, well, big pharma gets this bad rep, and people think that they're trying to, get as much money from the people as possible. They are actually still providing rather beneficial drugs to people. And this is one of those things where, again, like if you look at it, even in Ireland, I think it's 60% of the population are overweight or obese. Like, and it's not like that's a decreasing number, it's an increasing number. So if we have another line of intervention, maybe diets have failed this individual, maybe I don't know, fucking training interventions have failed this individual, lifestyle, whatever. Like, I would still like to have something else in the back pocket to be like, we have another line of helping this individual, right? So that's my perspective on it. Now, again, I am obviously aware that this stuff can be abused. This stuff can be a first line intervention for some people, and they don't make the necessary adjustments in other areas of their life. However, look, you're going to find this stuff online anyway, and I'd rather people got a smarter, again, we're still idiots though, a smarter breakdown of this stuff, so you can at least tie it back into your overall understanding, whether you're an individual who's just interested in this stuff, or you are a coach yourself who potentially deals with people that are overweight, and in particular obese, that are probably likely to engage in some of these things, like potentially, I don't say likely, potentially engage in these things at their doctor's supervision, not at yours. And also, just as a thing that, like, again, like myself and Gary enjoy, it's like, look, obviously we're in the health and fitness industry. We have lots of friends who do recreational drugs, and then we also have lots of friends that do bodybuilding drugs, and a lot of these things are in the bodybuilding world, or potentially will become part of the bodybuilding world, because they, again, work on the same stuff, the energy in, energy out stuff that dictates your body composition. And well, not your body composition, I should say, dictates your body weight. And obviously that's something that, like, bodybuilders, fitness enthusiasts are interested in, right? So with that out of the way, I actually think we're not going to touch on the first stuff that we're going to touch on is not actually related to obesity specifically in terms of the management of that. But I wanted to just, touch on these drugs, first of all, to kind of highlight that it's not all just about weight management, because when you're dealing with an obese individual, or you are an obese individual, one of the things that you really want to care about, probably above all else, is your health. Like that's what we're actually, that's the intervention that we care about. It's not about, oh, let's try to get you down to 6% body fat and whatever. Like, who cares about that? Like, the actual goal is to increase your health. And obviously weight loss is one of those ways, or weight management is one of those ways. But ultimately, we want you to be in a healthy position regardless of weight. Now, of course, look, we've talked about it before. We've discussed it. At those heavier body weights, at those higher body weights, that is less and less likely. However, maybe we do have an individual that has tried dieting, they can't get control of their hunger, they can't get control of their exercise, their lifestyle, whatever happens, and they still want to try to, not die. I'd like to, again, have interventions that could potentially help this individual. So with that in mind, the first thing, again, in these health supplements, or sure, I should not say supplements, in these health medications, the first thing is like a high cholesterol medication, right? Like a statin intervention. Again, if heart disease is one of the main contributors to death, full stop, in the world, and also especially relevant to those dealing with obesity, it makes sense that this is potentially an intervention that we could very easily bring in, that helps lower the risk of dying of heart disease for these individuals. So a high cholesterol medication, statins are just the one that most people know. I'm sure there's a ton of other interventions that you could talk about with this, but I'm just statin, great. If you have high LDL, I don't see why not. Do you have any thoughts on that, Gary? No thoughts on that, Gary?
Sorry, it cut out there for a second. I think you asked me what are my thoughts on statins.
Yes.
Yes, statins are widely prescribed and pretty effective drugs. So yes, there's absolutely a role for lipid-lowering drugs in someone who has obesity, provided there is a relevant risk there. Okay, so if someone has obesity, their BMI is elevated, but they have low LDL, high HDL, low triglycerides, then it's not necessarily the case that it would be useful then, unless someone has had a prior cardiovascular event, for example. So yeah, the indications for such drugs effectively vary depending on family history, whether you smoke, what your current lipid levels are, whether or not you've had a previous event, etc. Okay, so there's many different things that would inform that decision, and lipid lowering drugs do go beyond just statins as well. So it does really vary by country as well, because some of the drugs, such as the PCSK9 inhibitors, are very effective but also very expensive. So it depends on, whether you have healthcare insurance, are you going to pay for this drug outright, etc. So yeah, lipid lowering therapy is definitely something that would be relevant in the context of obesity.
Yeah, this is like, again, this probably holds true for the vast majority of the stuff that we're going to talk about today. Like, we might talk about a specific drug or maybe class of drugs, like I just said, statins there. But realistically, look, the free market prevails, and there's loads of companies out there that want to solve this issue. So there's probably multiple avenues towards actually, again, in this case, like lowering like blood lipids and lowering your cholesterol. Like there's definitely loads of different companies trying to get that business. So there's loads of different drugs. They might be the exact same type of drug, like a different statin, like a torvastatin, or there's a load of different statins, but there also might be through different mechanisms. And, again, some of them might be more beneficial. Some of them might have different side effects. Again, expense, the cost, all that kind of stuff, like, has to be taken into account. And that's, again, why you consult with your doctor for this stuff. We just want to be like, right, these are, again, something to be thinking about. The next thing then is high blood pressure medication, right? Such as ARBs or ARBs. I call them ARBs. I think you call them ARBs, Gary. What are your thoughts on that? Like, I like telmisartan, but what are your thoughts?
I just say angiotensin receptor blockers. Simple.
Yeah.
Just say the full word. But yeah, again, very, very, very similar discussion to the lipids discussion, where the management of high blood pressure, there's so many different medications, ranging from, as you say, the ARBs to ACE inhibitors, calcium channel blockers, beta blockers, diuretics, etc. So there's many different types of drugs, and again, that would vary depending on the cause of your hypertension, and also even ethnicity. The actual prescriptions, the line of first line drugs, second line drugs, etc., actually varies by ethnicity. It also varies by age, and also the severity of hypertension. So, for 90, that's going to require different treatment to if it's 180 over 110, let's say. And obviously that all comes back to diet and lifestyle as well there too. But yeah, plenty different drugs there in those classes of antihypertensives. But again, definitely something that's relevant in the context of obesity.
And then in the next one, moving on from that, because look, the whole podcast is basically going to be us talking about drugs. Some of them are really cool. Some of them are just like, okay, look, again, this is not a high blood pressure medication podcast. We're going to get through these so we can get onto the actual obesity drugs. But again, like, that doesn't mean that that's any less relevant to the actual issue. Like, again, if you were an obese individual and look, your blood lipids are fantastic, your, I don't know, cardiovascular fitness is fantastic, all these other measures are fantastic, but you just have high blood pressure, like, obviously that's going to be more relevant to you. But unfortunately, I can't give generic advice, right? First of all, I can't give advice in this area because I'm not a doctor, but I also can't just be like, oh, I'm generically going to talk about this stuff, because it is so specific to the actual individual. And then also, the various whatever classes or whatever that they fall into in terms of, like, again, age, race, ethnicity, if you will, and like all those kind of things. It's like they are all relevant, and a competent doctor is going to be the one that needs to go through that with you, taking into account your case history, etc. Right? But anyway, look, the next one then is metformin. Right. This is, we'll call it a blood glucose lowering drug, although it does far more for individuals than just that. Obviously, it's mainly prescribed to diabetics, which again is relevant to individuals that are dealing with obesity, right? But also, which is really interesting, and we'll come back to it in another section, metformin does actually, like, modulate the hypothalamic like appetite regulatory centers in the brain. So that's obviously really relevant to obesity if you are now in a position where you're not as hungry anymore. And that's something that you will see as well documented when people go on metformin, where they're just like, oh, I'm not actually really that hungry anymore, which is obviously great for helping them manage their blood glucose to an extent. Obviously, you still need to eat stuff, but if they're just not eating as much, then they're able to get a handle on their blood glucose a little bit easier. And then obviously, in the context of obesity, that is a beneficial thing, because again, we're modulating that calories in, calories out overarching theme, but also, which is also quite relevant in this case, and we'll touch on it further on in the podcast. And it also has alterations in the gut microbiome, or I should say, it alters the gut microbiome in potentially a beneficial way for individuals that are dealing with obesity. And look, the mechanisms of all of this are not as well understood as you would like them to be, or rather as we would like them to be. And like, I know some of the like top researchers in this field, and even they would be like, oh, I think it works through this. And this other person who's, again, top researcher would be like, well, I think the main mechanism is this. So like, it works through multiple things. However, in the context of obesity, and specifically in the context of individuals with obesity that are dealing with blood glucose regulatory issues, metformin can be a fantastic drug. Again, if it's prescribed by your doctor.
Yes.
Anything else to say on metformin? No?
No, I guess just one kind of point that's going to be relevant to other classes of drugs as well. And that is that obesity may not exist on its own. And for example, if someone has obesity and type 2 diabetes associated with that, you might be looking at the relevance of a given drug, not just related to whether or not it causes weight loss, but also glycemic control. So like you say there, metformin is something that might be prioritized in a patient like that because of the glycemic control element. And the same thing could be said for other drugs like the SGLT2 inhibitors and the GLP-1 agonists. So there are the GLP-1 agonists we'll definitely touch on again later on, but that's just an important point to consider, because there may be drugs that will be used in the context of diabetes that may actually potentially promote weight gain or make weight loss more difficult, such as insulin, such as sulfonylureas, and one class of drugs that we actually discussed in a previous podcast, and that was the thiazolidinediones.
I'm so glad you said that, because I cannot say that.
The thiazolidinediones. And interesting, I think, in that podcast was that despite the fact that they promote weight gain or can promote weight gain, they actually reduce liver fat and increase insulin sensitivity. So those drugs might be used in the context of someone who has type 2 diabetes, let's say. But if you were trying to approach this from the perspective of, all right, this is where we're trying to target obesity and reduce obesity, then you might actually, or a doctor might actually shift the therapeutic emphasis from some of those drugs to more of metformin, as we say, maximize the metformin dose as tolerated, GLP-1 agonists, SGLT2 inhibitors, etc. So I'm just bringing that point up because the kind of treatment decisions can become complicated by that stuff, because there's also, we're going to touch on a number of stimulant or sympathomimetic drugs later on. And one of the things to consider there would be, for example, if the patient has hypertension or heart disease already, or arrhythmias, you mightn't actually want to be giving those drugs because it could actually worsen some of those conditions that are associated with obesity. So as you can see, these decisions end up being kind of complex because of what goes along with the state of obesity.
Yeah, and this is actually really important to understand as well. First of all, when you said metformin, you were like, oh, we bring it up to the, like, we'll call it maximal tolerable dose or whatever. Like, first of all, to like, what does that actually mean? It's like, there's, after a certain amount, there are side effects to these drugs. Well, there's probably side effects to the drugs at all stages. However, there's a certain point where it's like the side effects are outweighing the actual effects, And I always say this when talking about drugs, even though I just said like side effects, like there are no side effects, there are only effects. Right? Like you can't just go, oh, these are the side effects because I don't like them, and these are the effects because I like them. It's like you're getting all of these, that's just the effect of this drug, right? And that is something that like doctors have to deal with all the time, where it's like you have to manage all these effects that you don't necessarily want, and you can't just escalate the dose until you get to a stage where you're like, oh, look, yeah, you have all these side effects that are just not what we want, but you're getting a continually greater effect of this, whatever we do want. Like that's, if you're shitting yourself 24/7, like you're not going to stay on that drug, like that's a side effect. Like it's not going to be a drug that you stay on, right? Even if it is helping your whatever, right? So that is something to take into account. But then also, which is really important, a lot of these have like drug on drug interactions. It's not just a case of like, oh, I'm going to take a little bit from here and a little bit from there, and I'm just going to combine this like therapy that I've made up in my mind and said, oh, this is going to be the way to fix the issue. it's just not going to work, like, because again, they have drug on drug interactions, and then also they have, we'll call it drug on human interactions, because it's not like obesity is this one singular thing. Like Gary said, you could have obesity and you might be thinking, oh, I need to, I don't know, manage my weight, so I'm going to pick from that like stimulant category, which we'll talk about in a second. But then also you have to take into account that you have heart disease in your family, you have high blood pressure, you have all these, like, you were born with a hole in your heart. I don't know, fucking any of these things. It's like you can't just pick and choose without actually looking at the case history of that individual, you know? So it is more complex than just, you know, here's a few drugs that work for this issue. It's like, no, like if they really worked for this issue and they had no effects like that we didn't want, we'd have already solved the obesity epidemic. You know, if you think a company who has a drug that solves all of this stuff with no side effects, I think they would be making fucking bank off this stuff, you know, like everyone would be on that drug, right? But anyway, it doesn't exist. So we're going to continue with the podcast. The other thing now, the next bit that I'm just going to touch on before we actually get into the real obesity drugs, there are a lot of supplements, like just, you know, generic supplements that you can get in a supplement store or buy online or whatever, that potentially do have beneficial effects for managing obesity. Like berberine, we just touched on, metformin has some similar qualities in terms of blood glucose management. However, I'm hesitant to just say like, oh yeah, go ahead and get berberine, because it does have other effects as well. And while it is beneficial from the perspective of blood glucose management, I don't know if it does have the same effects overall in terms of your reduced appetite, the changes in the gut microbiome, because I don't think there's as much research on it, because it's not a drug, it's a plant derived thing. So it's like they can't patent it, so we don't have the research. So even though you'll see online people saying, oh, this is fantastic, blah blah blah, it could solve the obesity epidemic, solve diabetes, solve whatever, it's like, okay, well, show me the research for that, and they can't, you know.
It also might reduce your gains, which is incredibly weak, you know?
Yeah, I was gonna just, I didn't want to mention that, but yes, obviously. But look, even like
Sorry.
potentially metformin does that as well. I know there's studies again that say that it doesn't, but look, ultimately they're going to tell you that it doesn't as well. You know, it's like, oh, it's going to work for your muscles as well. But anything that's like, you know, upregulates, we'll call it like, we'll say through that AMPK pathway, like it potentially does interact with your ability to build muscle. But that's the case with all weight loss drugs. It's just going to interact with your ability to build muscle, because it goes back to that simple fundamental equation that we've talked about multiple times, like calories in, calories out. Like you can't build muscle without enough calories. And it's the exact same with trying to build muscle in a calorie deficit. Like if you're in a weight loss phase and you're like, oh, I'm going to build copious amounts of muscle, it's not going to happen, right? So the same types of drugs that we're going to use for weight loss work through the same mechanisms as a calorie deficit, because, you know, most of them are actually trying to elicit a calorie deficit. So they're going to limit your ability to build muscle, you know? But anyway, on berberine, do you have any other thoughts?
Nah.
Fantastic. Then two other ones, which are just, you know, like foundational kind of supplements for a lot of people, and that's a fiber supplement and a protein supplement, right? Like whey protein or milk protein or whatever, right? And you might be thinking, why are we covering those things? But again, they are, we'll call them lifestyle interventions or diet interventions that are actually, you know, fairly effective. You know, fiber is really quite filling, and it also has effects on like lowering your blood cholesterol, right? So it's like this has, you would almost call this like a medical intervention if you have something like whatever that thing is called, a psyllium husk, like a fiber supplement of that, like that could be very effective at, you know, helping you feel fuller for longer, like a lot of these drugs do, and then also lowering your blood cholesterol, like your LDL cholesterol. And how is that any different than a medication? You know, really, it's not. And like, obviously it is, because it's not a medication, but at the same time, it's like that is an intervention that you are doing that has similar effects, right? And the same with protein, again, very filling, also potentially helps with the building of muscle, which then provides a sink for blood glucose, all the stuff that we normally talk about when we talk about the benefits of building muscle, right? And there are some obviously over-the-counter, well, some of them are over-the-counter, some of them are gray area stimulants, like ephedrine, yohimbine, or rowalcine. Like they are stimulants to an extent. Again, I'm kind of less enthusiastic about all the stimulants for weight loss because, again, there's cardiovascular issues with this population generally, and it's not beneficial. However, you will also see them often put out there in weight loss pills and different things like that. So it is to be noted. And obviously in the bodybuilding realm or the health and fitness realm or whatever you want to call this stuff, like those drugs are used, or those supplements are used to elicit an effect in terms of weight loss. So it is something to be aware of. Do you have any thoughts on that, Gary?
Nope. Good.
Fantastic. Right. Now we can actually get into the category of the stimulants. And one of these, again, is a supplement that you could take over the counter. However, I'm classing it in the stimulants just to kind of break in the conversation, even though I did just touch on like ephedrine and stuff. And that is caffeine, right? Because you don't often think of that as like an intervention. But again, in this class of stimulants, like what's the goal of a stimulant? The goal is to make you have more energy or make you feel like you have more energy, get that adrenergic signaling going. So it's like you're more kind of hyped up, you're able to move around more, thus you're able to burn more calories day to day. It also has generally the effect of, dropping appetite a little bit, like all of those stimulants. Again, if we just go back to our basic like nervous system 101, like you have your sympathetic nervous system and then you have your parasympathetic nervous system, your parasympathetic being your rest and digest, and your sympathetic being your like, ready to fight type deal, if you are stimulating your nervous system in a way that's putting in this kind of like, I'm ready to fight, you are inherently taking away energy, we'll say, from the like rest and digest stuff, right? They're kind of antagonistic to each other, right? And that's not truly the case. Again, simplifying things here. So if you are taking something that stimulates you, you are doing less stuff that is like, rest and digest stuff, right? So you generally don't feel as hungry when you're taking these things. And anyone who's taking coffee, in the morning and been like, oh yeah, like I've got a little bit of like hunger suppression, like people who do fasting, like intermittent fasting or time restricted fasting, they'll often drink coffee in the morning as their first meal. So they get a little bit of that appetite suppression, like a black coffee in the morning, just get a little bit of that appetite suppression. So you could call this an intervention, a drug intervention. It's like, people are using it for drug-like qualities. And it also has these effects that would be beneficial for obesity related issues, right? So it's like, this is an obesity drug, right? And again, most people don't think of it like that because most people are, aware of like, oh, I'll just drink my caffeine. I'll just drink my coffee in the morning. That's not an obesity drug. However, look, it does fall into this category of stimulants. Do you have any thoughts on that, Gary?
No, I don't think so. That's good.
It's because you still drink coffee. You're on that drug.
Yeah, just stick with the black coffee and not the frappuccinos, like, and you'll be fine.
Yeah, that's obviously a really important thing to note, where like if you're adding 800 calories to your coffee in the morning or whatever, like that's obviously not going to result in any kind of weight loss. Even if you do get the kind of stimulant effects or whatever, if you're adding a lot of extra calories to your diet, again, going back to that calories in, calories out equation, it's not beneficial, right? Now, the next few, like there's a load of these drugs, and I just picked a few of these not because they're anything in particular, like, oh, they're really fantastic ones or whatever. Like I'm sure you could find 1,000,001 different stimulants that are potentially beneficial in this case. But again, we have to look at all the other stuff that's going on, the heart related stuff. So like you're not going to get some of the other drugs that I could definitely think of, and we will cover one or two of them later on. Like stimulant type drugs, you're not going to get them, done in a study. You're going to get them given out in a study because they probably will result in some cardiac events, because they're like very stimulating, right? But some of the other ones that are a little bit less, we'll call stimulating, obviously again depending on the dose, etc. And there's phentermine, phendimetrazine, diethylpropione, and phentermine topiramate combo. Some of those, again, like you can see them if you look up any weight loss studies in terms of like the pharmacological interventions. They're used. They seem to be quite effective. Some of them more than others. Again, they're doing the exact same thing as coffee here, which is our generic stimulant. It's causing this stimulant effect. It's causing this like CNS, like we'll call it. It's not CNS. It's more of your sympathetic nervous system upregulation. It's giving you more of a like, okay, get up and go, move around. So you move around more and thus you lose weight. There is obviously some other stuff that's going on, like, your heart rate goes up. So even if you don't actually move around more, like your body is technically moving around more. So you are kind of burning more calories on a day-to-day basis. And like, you probably notice yourself, like if you have a couple of cups of coffee per day, like you notice your heart rate is a little bit elevated. You probably notice that your body temperature as a result is a little bit elevated. Like that's all burning calories, even if you're not actually moving around more. Like it's still contributing to your overall caloric expenditure, even if, again, like you're not doing any formalized exercise as a result of all of that. Do you have any comment on those ones, Gary?
Yeah, I guess just knowing as well that like the kind of central effects here are quite important, especially when you're talking about like the phentermine terpyramate. I don't think that's prescribed in Ireland, to be honest. I know it's prescribed in the US, but I'm not entirely sure on that, to be honest. But yeah, there are central effects there in terms of like acting on reward related pathways and satiety related pathways in the brain. And that's the case for a lot of the drugs that tend to be effective. Generally, it's assisting with the other behavioral interventions, like trying to reduce overall caloric intake. And obviously, it goes without saying that we're not saying you should take any of these drugs anyway, because it's not the purpose of this podcast. But with all of these drugs, there are different side effects. And when you talk about topiramate, there are teratogenic effects in terms of pregnancy. Like you don't want to be taking it during pregnancy. And that's the case with many of these drugs. They tend to be contraindicated during pregnancy. But yeah, that's a doctor's discussion, really.
Yeah, and then also it's really important what you noted in terms of like most of these drugs, they probably do have multiple mechanisms of action. And
sure.
while some of them were like, oh yeah, look, this is what we're thinking, like these are in the stimulant category, like they might have other effects in different areas of the body. And that is just like, again, we have to categorize them somehow, you know? So like, this is not a full discussion is what I'm saying, right? Now, the next one is thyroid hormone, right? Which again, most people would actually be aware of this one because most people think that, oh, the reason that I am overweight is because I have a sluggish thyroid, right? Or I have low thyroid, which is just not really the case for the majority of people. Like, yes, for sure, there are individuals that have a sluggish thyroid. They have some sort of issue with their thyroid where they're not producing enough thyroid hormone. And as a result, weight gain is a little bit easier because thyroid plays a role in, we'll call it stimulating. That's why I have it in this category. You know, it's kind of like making you move around, making you do stuff. However, I don't think in most individuals that are obese, they have low thyroid hormone. In fact, like if you actually look at it, eating more is one of the easiest ways to get your body to produce more thyroid hormone, right? And now, obviously, there is a limit to that. You know, it's the same with insulin. Like eating more obviously is the best way to get your body to produce more insulin, right? However, again, there is a point of diminishing returns, and it's like you can only produce so much in a given day across a given year, whatever, right? And it's kind of the same with the thyroid output. So while you might think if you have a fundamental or a cursory understanding of how the body works, the different things in it, and you might have heard that people say like, oh, I have a sluggish thyroid, and that's the reason for my weight gain. Like, it's just not an intervention that is probably likely to be all that effective in treating obesity. Right? Even though you would think, again, looking at thyroid hormone and you read it on your like Wikipedia page or whatever, it's like, oh, it has all these effects. Like, you know, people who go on thyroid hormone generally lose weight, right? Which again is true. But for an individual that has obesity and has normal functioning thyroid, like it's probably not going to do a huge pile to just give them artificial thyroid or synthetic thyroid. Now it might. And again, that's something that you want to discuss with your doctor. However, do you really want to go on hormone replacement therapy potentially for the rest of your life just to lose some weight? Because at least with all these other drugs, like you could potentially come off them. Well, a lot of them anyway. But like with hormone replacement therapy, now it's not really the case with thyroid because you can't actually come off it and your body will generally start producing thyroid again. But it is one of those ones where I start thinking a little bit more of like, okay, is this something that you want to be on for the rest of your life? But what are your thoughts on using thyroid to help with the management of obesity? And look, I'm categorizing it as thyroid there. That's a relatively broad category, being generous, but like you understand the sentiment.
Yeah, and and thyroid hormone therapy, you could say, is effectively one of those that lies in the graveyard of obesity drugs, because like logically, again, you think, oh well, thyroid people who have hyperthyroidism, they tend to lose weight, so let's just give people more thyroid. But the problem with that is that when you begin to do that, you also get the other complications of hyperthyroidism potentially, including arrhythmias, for example, hypertension, bone loss, etc. So it's not really worth, like if you're trying to achieve weight loss from obesity, you're generally doing so for the purpose of improving health. And if you're accepting arrhythmia, hypertension, etc. as a trade-off, that's clearly not really a great trade-off, particularly where, if, as you say, longer term, the person might want to come off that because of those risks, and then potentially might be at risk of rebound weight gain. So again, it kind of lies in the graveyard of obesity drugs, really not really used, frequently, very frequently used by bodybuilders, and in the kind of fitness model space, but not prescribed for people with obesity, unless hypothyroidism is the cause, obviously.
Yeah, and this is one of those ones which also has like a huge number of side effects. And it's actually really interesting because like you can look at the health and fitness industry and you can see a lot of these side effects at play. You know, it's like it has side effects in terms of, like, we'll call it like digestive health. You know, people are like, oh man, like I was dieting and I had all these like severe bloating issues and everything. It's like, yeah, of course you did, because you were on thyroid hormone. Like it's like it's not side effect free, like you know. But it's interesting that you see that, like, if you know the drug mechanisms and all the side effects and all the, you know, whatever is going on, you can be looking at the health and fitness industry and going like, oh, it's very interesting that you all have these side effects, you know. But anyway, look, that's a conversation for another day. But yeah, look, thyroid probably not overly effective for what we want in this case. Even though, again, you know, on paper you would think fantastic drug, right? Now the next one I'm going to get you to talk about, and this is actually, I'm going to call it an asthma medication, even though that's being very generous. But there are also other ones that fall into this one, like salbutamol is generally the one that is used in like inhalers and stuff, as far as I'm aware. But there are other ones that are generally used for weight loss, again, by bodybuilders, by health and fitness enthusiasts, whatever, and that is Clenbuterol. So Gary, tell me a bit about Clenbuterol.
Clen, baby. Yeah, you've probably heard of this, and if you like, you may even not know the reference, but you'll see in a lot of like fitness bodybuilding memes, eat clean, train hard, and that's obviously a joke related to eat clean, train hard. But clen is a fat loss drug, train is, and you know, just become the ultimate man drug. But yeah, clenbuterol effectively falls into a very similar category in terms of having very stimulatory effects. A lot of people who will be on clen will report sweating a lot. You know, they'll feel their heart rate, they'll have palpitations, they might have difficulty sleeping. So again, it kind of falls into this category of stimulants. As Paddy said, you know, it is in a class of drugs like others, like salbutamol, which would be an inhaler for people with asthma. And that's obviously a much lower dose, or not as potent, and it's specific to the airways because it's inhaled. So yeah, that's basically it really about clenbuterol. Like, it's not something that is going to be prescribed for obesity once again, but is frequently used within the health and fitness space, so is still relevant, I guess.
Yeah, exactly. I've nothing else to say on that. But anyway, look, The next one then is it sounds pretty fucking ridiculous, but look, we know bodybuilders. We also know that a lot of them have no problem experimenting with drugs. I also know a lot of people, even in, like, you know, we'll call it logical or brain related endeavors, they use drugs that are related to this, and the drug is meth. You know, like, you hear people fucking smoking meth, same drug could potentially be used as a weight loss drug, right? Like, you think of your typical meth addict, right? They probably don't weigh a lot, you know. So this is one of those things, again, falls under the category of we'll call it stimulants, because it has that kind of stimulating effect. And look, you don't actually have to be fucking smoking crystal to be getting the effects of this. Like, I'm not going to say like, oh, all these individuals with obesity, here's a fucking bowl, let's go fucking have a, have a go. But you can get it in actual drug form, in terms of they literally give it to kids in like Adderall, like that is literally, well, not literally, but it is basically the same drug as meth, right? So this is potentially a weight loss drug. However, again, the side effect profile is probably not beneficial for someone that has obesity or is even overweight. Like a lot of people I know personally that have taken like Adderall and other, we'll call them study drugs, like Ritalin and stuff, and they've ended up with issues down the line because of that, right? So it's not without its consequences. And if you are already in a population that has a higher risk of heart disease or heart attacks or cardiovascular events, it's probably not something I would do. However, you probably will see this used in the health and fitness industry, and I say health and fitness industry liberally, because like it does actually result in weight loss, right? And it also generally results in more, we'll call it adrenergic signaling, more like hype before a lift, so if you're going in, you want to crush your session, like you could argue that smoking a bowl beforehand would be beneficial, right? Especially given that if it's going to lead to weight loss down the line as well, you're in a diet, you're in a deficit, you're feeling a little bit, fatigued, you fucking have some crystal meth beforehand, you go in just enough, so you're not fucking cracked out, and you go in, smash your lifts, you fucking lift like a lunatic. Also has appetite suppressing effects, so you're able to stick to your diet overall. Like if you know anyone who has ADHD and they take something like Adderall, they'll be like, oh yeah, I just don't really feel hungry anymore until the evening, so all of those things you would think would be beneficial for helping treat obesity. However, you're unlikely to see this as an intervention for obesity because the side effect profile is not beneficial.
Yep, and our business name is actually Triage Method, which is actually a play on this, because if you have a meth OD method, you're going to end up in the triage room. So that's basically what we base our whole business on.
Exactly, Gary.
But yeah, I'm not. Yeah, but if Patty wants me to add anything there, absolutely nothing to add. Don't take meth. That's all, really. Not advised.
Anyway, the next one then, again, bodybuilders just seem to take all the fucking risky drugs. I don't know what the fucking crack is here, right? The next one then is a DNP, right? Which I'm not even going to get into this too much, but it is a protein uncoupler, leads to, we'll call it excessive heat generation, where your body is just not actually able to make energy from the energy that you're eating, like the actual, like we'll say mitochondria, like again, I'm oversimplifying it here, but the mitochondria is just not effective, and you're getting a lot of like proton leakage, where you just basically aren't making the energy that you would expect. Like you think, oh, I would burn this 1 gram of protein and I would get 4 calories of energy. Like it's just not happening, and you're just wasting that energy to the environment as heat, right? And this is fucking wild, because DNP used to be given out as a weight loss drug. Like it literally was given out as an obesity drug back in the fucking day, where you could order it, not even online, because it was before the fucking internet. And like you could order it from like those mail-in magazines, like pre-1950s and stuff, So why might you not take this? Even you're thinking, oh, it's actually really beneficial. It just the only side effect is like it excessively generates some heat. You basically don't get all these calories that you've been eating. You can eat to excess, and all that happens is you just release some heat. Well, unfortunately, that heat can cook you.
Yep.
So if you take too much, if you take, well, not even that, you literally just fucking cook from the inside out. Like if you take too much of this, which is again, it's relatively easy to do. If you take too much of this, you potentially could die. And there's no, like, I don't know of any intervention drug wise, or even like, put you in an ice bath or anything. I don't know of any intervention that could potentially help you if you do overdose on DNP. You're pretty much like, you're fucked, you basically cook from the inside out. Like even if they put you in an ice bath, like your body is still wasting all of that energy and it will continue to do so until the drug is out of your system. And this was actually a really huge issue. Well, I would say a huge issue as if thousands of people are fucking dying every day from this, but it was a bigger issue when they actually stopped producing DNP like in actual fucking labs, and they started getting it from like China and stuff, because it's really hard to dose it accurately if you don't know what the actual dose that they put into this capsule or this fucking little tube or whatever they gave you. And then again, you just overdose without even realizing. But anyway, look, DNP is it's just a terrible,
don't take it.
terrible fucking drug. Would not recommend in the slightest. So anyway, look, that's all the stimulants out of the way. There are hundreds, thousands potentially of other stimulants that we could talk about. However, ultimately for obesity, I'm just not a fan of the stimulant class. I'm just not a fan of the side effects are just not good for what we want in this population, right? They're good for what we want in terms of they generally blunt hunger and they generally make you move more, therefore affecting both sides of the equation that we're talking about here, energy in, energy out. However, the side effect profile is just generally not fucking beneficial. Before we move on, Gary, do you have anything else to say on the stimulant class? Do you think there's ever a time point where you're like, yeah, look, the stimulants make sense? Like, obviously there is at a certain point where, look, you can have a fucking cup of coffee if you need to, but is there any point where you're like, yeah, okay, the stimulant class, it makes sense?
Yeah, I mean, like the phentermine topiramate combo, obviously, but that's not something that people are typically thinking about when they talk about stimulants. Like, we're more so thinking about the kind of cleanse side of the spectrum, cleanse, thyroid hormone, DNP, as we said. Like, if we want to put them all into that category, like, yeah, like where you start to mess with those things and like get those really driven up sympathetic nervous system effects, like effectively all of those things fall into either increasing energy production or not even energy production, just wasting energy, or speeding up lots of processes that can lead to arrhythmias, increased stress in the heart, etc. So there's big trade-offs there, and ultimately there's not many there that are approved for people with obesity.
Yeah, and ultimately, look, if I had obesity and I was looking at pharmacological interventions, I wouldn't be picking from these classes. So I probably wouldn't recommend them personally, right? Now, the next one is actually far more interesting and far more fruitful in my perception of all of this stuff. And that is the drugs that are related to hunger management, right? And there's actually fucking hundreds in this class, thousands in this class. And we're not going to cover them all. We're just going to cover some interesting ones here. But in my mind, I'm like, look, if you can actually get a manage on hunger, and obviously, look, we just talked about the stimulants. They do to an extent manage hunger, but they do it with a much worse side effect profile than what we want, especially when we consider that there are other drugs that potentially fall into this category of hunger management and are far more beneficial. And look, we'll just get into the hunger drugs, right? So the first one is lorcaserin. I actually don't know a huge amount about this, but it is actually mentioned a lot in relation to hunger. I haven't looked into it too much because I think there are better drugs available. However, I'm not a fucking doctor. I'm definitely not your doctor, whoever is listening to this. So if your doctor has prescribed it, they probably have a good reason to prescribe it. But what are your thoughts on that, Gary, or do you know much about it?
Yeah, it is one of the centrally acting drugs. Like, it's a serotonin receptor agonist, effectively. But I think it was pulled from the market in the US. Not entirely sure. Don't think it's prescribed in Ireland or Europe. But again, it's one of those that has centrally acting effects, which is the case for a lot of the efficacious drugs. So yeah. Pretty sure it has evidence to support its efficacy, but I'm not sure of rates of prescription now, to be honest.
Fair. Anyway, look, in my mind, I'm like, it's a boring drug. There's cooler ones. That's how I categorize these drugs. It's not whether they're effective or anything. I'm like, I just like the biochemistry of them. I'm like, that's fucking cool. Because again, I'm not a fucking doctor, so I don't have to care about the other stuff. Now, the ones that I think are really cool are all these like GLP agonists, GLP-1 agonists, or your glucagon-like peptide agonists, right? So most people, I say most people as if they all fucking are aware of GLP and what it does. But But most people that are into this stuff understand that GLP-1 is obviously part of this whole hunger cascade and all the stuff that's going on here. We're not going to get into that because the discussion would be far too fucking in depth then. But there are a class of drugs, or I say a class of drugs, I suppose. Yeah, that's right. And there are some drugs that work through this as GLP-1 agonists or GLP agonists. Some of them are short acting, some of them are longer acting. And this is actually, most people are aware of this because recently, well, I say, well, most people in the British Isles at least are aware of this because there was a lot of talk about it recently enough in the NHS using one of these drugs, semaglutide, in combination with diet interventions and stuff as a hunger management tool, right? And in my mind, I'm like, this is actually a fantastic drug because it basically makes people not hungry, right? And as far as I'm aware, they actually originally found and then isolated and then synthesized from it that semaglutide from Gila monster venom, right? Which is also a fucking cool story in and of itself, like this is a cool drug, and then how you found this drug and got it is also a fucking cool story. So in my mind, I'm like, the cool drugs, they increase insulin secretion and reduce hunger, and they also enhance, I suppose is the right word, the growth of beta cells in the pancreas, which again is potentially really beneficial for someone who's dealing with blood glucose regulation issues, or like all that stuff that we've talked about before in terms of like ectopic fat storage in the liver, pancreas, etc. In my mind, I'm like, look, these utides or glutides are really beneficial. There's also dulaglutide, liraglutide, exenatide, lixenatide. Yeah, I think that's right. And some of them are short acting, some of them are longer acting. Again, there's differences in terms of why you would choose a shorter acting one or why you would choose a longer acting one. Not going to get into it in this podcast. However, I could definitely see in the next few years, if it isn't already happening, although I have my ear to the ground and that stuff. If it isn't already happening in the bodybuilding world, like I could definitely see them using way more short-acting GLP agonists, because it just seems like it makes dieting so much easier where you're not hungry. Like you just don't feel hungry because you are getting this GLP-1 agonism. But what are your thoughts on all of these, Gary? Because I'm quite excited about these. I actually think these are, a really interesting intervention, and I think over the next few years, in the general obesity and weight management sphere, this will become more and more of a like first line type intervention because the side effect profile is actually relatively low. Like there's some like nausea and stuff like that. But other than that, it's like, maybe some like, diarrhea as well. But other than that, I'm like, look, it's fucking grand. Now, unfortunately, a lot of these have to be injected, which is, obviously a barrier there, and potentially cost is an issue. I'm not sure on the cost and stuff. But what are your thoughts?
Yeah, I think the semaglutide paper was particularly groundbreaking, we could say, because it was released in the New England Journal of Medicine earlier this year, and it got shared around everywhere, like in popular press and in kind of research circles, I guess. And the results were, pretty legit. And I think the good thing about that drug is that like the liraglutide daily injection, which is obviously pretty laborious, whereas the semaglutide is actually a weekly injection. So weekly subcutaneous injection, which means that it's a relatively small needle. So it's not like a big, massive, scary needle that you need to inject. So there's that. But I think that you're right in that you could see this potentially drifting into bodybuilding circles, because a weekly injection that's just subcutaneous, meaning that you don't have to put, more drugs into actual intramuscularly or deal with the side effects associated with oral drugs. I think that there's definitely potential there for that to drift into the bodybuilding world, but we'll see where that goes. As you say, the side effect profile, not too bad really, like, in terms of like as weight loss drugs go, when you look at the extent of the benefit of weight loss, like if you get the time or you're interested in this stuff, do have a look at the paper in the New England Journal of Medicine, because the graph just really stands out. Like there's such a huge difference between the behavioral intervention alone and the behavioral intervention plus semaglutide. So yeah, I think it's really interesting. And as far as I know, it is approved in the NHS. I'm not entirely sure. I'm pretty sure it is, as you said. but I'm not sure if it's actually available in Ireland yet. I don't think semaglutide is available in Ireland. I think liraglutide is the main one that's used, but not entirely sure. But again, this is kind of more like this is where you just deal with kind of medical politics, really, because you can read all this research about these drugs, but then you're like, oh, what's actually available? And then what's covered with my medical card, for example, and blah, blah, blah. So yeah, things are messy.
Yeah, and especially just, this is one of those things where, like, if you ever do any research on this, or like, I don't mean actual research, I mean just like trying to research this stuff yourself, like it's so hard to sift through all those things because you don't get all the politics around it. You know, it's like, oh, well, why is this not covered by this place or this place? You know, like even just going back to like, you know, everyone's dealing with now, where like this AstraZeneca stuff, you know, in terms of like the European Union's you know, fallout with Britain, or I should say Britain's fallout with the European Union, and then this whole like back and forth in terms of the AstraZeneca like vaccine rollout and all this. Like, it's like you don't really, like, if you're looking at the papers on this stuff, you might go, oh, AstraZeneca vaccine, that's fantastic, that's the one I want to get. But because of the politics around it, it might not be available to you. And it's the same with all of these drugs in terms of, you know, this drug might be fantastic, but it's not available in your country, or again, it's not covered by your medical insurance, or, you know, whatever, right? But in terms of the bodybuilding stuff, because, you know, that's what I think is cool, like that liraglutide, I think has a lot of potential in this sphere, because it's a shorter acting one, which has a lot of benefit in terms of, like, we'll say dieting for bodybuilding shows and stuff. So I can definitely see that being like blasted out in the next while, if it's not already been some circles. But obviously, again, like all of these drugs have side effects, and we will find out the side effects with bodybuilders using it as soon enough, I suppose.
Yeah, they're the lab rats really for all these drugs, because they'll just take whatever.
Yeah, and the unfortunate thing is they always tend to take higher and higher and higher doses, which is good from a learning what goes wrong perspective, which is not great for the people involved, but you know what I mean. But unfortunately as well, they all tend to not tell other people what they're doing, which leads to a situation where people keep making the same fucking mistakes because, oh, I don't take those drugs, when you go into their house and they have this medicine cabinet full of fucking like all of these drugs that they don't supposedly take, you know. But anyway, look, that's a story from another day. There's other ones that also interact with this hunger stuff. One of them, which is interesting enough, because you wouldn't necessarily expect it, is melanotan 2, which stimulates melanogenesis, which is, you know, tanning effectively, right? That's what it is, you know. And you might be thinking, like, what, like, why are you taking a drug that would make you more tanned or make you more like brown effectively? Like, you know, you're getting that kind of tanning, you're getting that melanogenesis. Why would that interact with as a like obesity treatment drug? However, it has the side effect of hunger suppression, right? Which is really interesting because, again, obviously what we're looking for is to affect that whole energy in, energy out equation. And if you take this drug, unfortunately, again, I think you have to inject it. You could get a sick tan while you get fucking shredded because you're not hungry, because you got this hunger suppression, you know. However, again, look, I'm probably not going to recommend, or I would not recommend in general, because I'm not a doctor, this one, because there are more effective drugs out there, and it's not, there are side effects. One of the side effects is boners, just in case anyone was wondering. So look, there, it is what it is. Do you have any thoughts on melanotan 2? Because look, it's not something that I would generally recommend even looking into too much, because while it's interesting that it has this side effect of hunger suppression, I'm like, ultimately, like, you know, it's just not that great.
Yeah, I'm pretty sure it's just highly unregulated and isn't actually prescribed for anything. So if you're getting it, you're likely getting it like, you know, black market stuff.
100%. Then the next one, which is actually another one that's really, really fucking interesting, and that is leptin, right? Because most people are aware of leptin and ghrelin, in terms of leptin and satiety and stuff, but like you can actually inject leptin, right? Like you can actually inject leptin and get the effects of leptin, right? Which is really interesting, again, in the context of, first of all, people dealing with obesity, but then also people dealing with the effects of, you know, we'll say extended dieting in terms of like, bodybuilders, that kind of stuff. But do you have any thoughts on leptin as an intervention for obesity, Gary?
Yeah, leptin was super interesting. Like when it was first discovered, because it's not very long since it was discovered, and it was, an area of excitement in terms of research, but unfortunately it just isn't actually that useful unless you have leptin deficiency, which is very rare, but does occur. And in those,
just on that, like we will actually touch on that leptin deficiency later on, but anyway.
Yeah, and in those individuals with leptin deficiency, it's fantastic that leptin has been isolated and synthesized. So that's brilliant, but doesn't really look like there's much of a role for actual leptin use. Otherwise, leptin and ghrelin are often thought of as being kind of opposite sides of the scale, where leptin's going to increase satiety, ghrelin's going to increase hunger. And there have even been, I think, some experimental trials on vaccination against ghrelin as well, which is pretty fascinating. But I'm not sure they've actually led anywhere either. So yeah, there's literally thousands and thousands of potential therapeutic avenues here. A lot of them just end up going nowhere, but there's definitely a lot that's there for the future as well. But yeah, leptin, if you've got a leptin deficiency, brilliant. Otherwise, just
and also, like, again, you have to inject this, so you have to be thinking of the intervention itself, how you actually administer it. Most people don't want to inject stuff as a general rule, unless you're a bodybuilder maybe, or a heroin junkie. So you have to inject it. That's a barrier to it. It also seems to be quite expensive from what I can gather. And like you said, like it's not excessively like kind of effective, like it's not like, it's just not what people thought it would be, and then also we have to deal with the fact that like you can get leptin resistance, so it's not just a drug that you can just keep taking more of and more of and more of. It's just like, insulin. It's like, well, insulin's a little bit different because it could immediately kill you, but it's like you can get insulin resistance, so you can get leptin resistance, and this is something that, again, obese individuals potentially have to deal with, not from just taking the drug, just from general life, just the lifestyle that they lead, right? But then also, look, Gary mentioned that there's individuals out there that are potentially leptin deficient, like they just don't make this, we'll call it a satiety hormone. It does a lot more than that, but we'll call it a satiety hormone, right? And if you're obviously deficient in a hormone that makes you satiated, so you never feel full, you're going to overeat, like think about why you stop eating when you are eating your plate of food. Usually it's either because you eat the whole plate of food or you're full, you're done eating, like imagine you never felt full, you're just constantly in a state of like, maybe not hungry, like it's not necessarily hunger, but not full anyway, like you can never actually fill up with food, that's obviously going to lead you to overconsume food, right? So if you have an inbuilt error in your genes that code for leptin synthesis, and you have a deficiency in leptin as a result, like the only way you can actually fix that is with leptin injections, or the next intervention, which we'll call like genetic alteration. Like you could use something like CRISPR technology. You could use that to intervene and edit your genome, and thus not be leptin deficient anymore, produce a normal amount of leptin in response to your lifestyle, right? And that's probably a little ways off in terms of like, it's not something that we do right now, as far as I'm aware. Like I'm actually invested in a load of companies that are like, genomics revolution type companies, because I think that will be a huge thing in the next 5 to 10 years. However, right now it's kind of one of those like pie in the sky type, like, oh, we know this is a thing that we could do. And like you constantly see in the media, this new thing comes out like, oh, we're able to use CRISPR technology, CRISPR-Cas9 technology to edit this part of the genome, and we cured blindness. Like that was one that came out a while ago, or we did something with this other disease and we cured it because it was a genetic abnormality, which is really fucking fascinating. And again, in this context of obese individuals, if you have a leptin deficiency, editing your genome would be incredibly beneficial to not have a leptin deficiency anymore, right? And there are other, genes involved in obesity in terms of, hunger regulation, satiety regulation, in terms of like even like your ability to store body fat. Like there's going to come a point in time where you could, I don't know, maybe effectively always be insulin sensitive. Like there's going to be genes found that it's like, oh, this codes for this, that also interacts in this pathway. And you can basically end up with a phenotype that you only build muscle, like it's potential like there, because there are other animals that, like we talked about previously, like chimpanzees, they don't store body fat, or they do store body fat, but like they just have lower levels of body fat than us, and so you could argue that we could genetically become more like them. Again, it's not beneficial, as we talked about, because humans are the top of the fucking food chain, my boys, because we have extreme adaptability, and one of those extreme adaptabilities is the ability to store fat and thus survive long periods of time without food. But yeah, like CRISPR therapeutics, phenomenal for any of these gene alteration or abnormalities. However, not something that you're probably likely to go into your doctor's office right now and be like, I want I want those crisps that they were talking about. Like that's not going to be a case. Do you have anything to say on the genomics revolution, Gary, and the genetic altering revolution?
No, and I do actually have to urgently finish up the podcast, so I might let you finish up if you don't mind.
We have two more to talk about. So
naltrexone, bupropion, and orlistat is what's left.
And then we're just going to touch on the bariatric surgery. That's just touch on it because it's not something that like.
Yeah, well, I'm peeing, so I'll be back.
Fantastic. I'll let Gary come back for the antidepressants one because it's cool for that. There's another one, orlistat, which is a drug, an intervention that can be used, which basically stops, inhibits fat absorption, right? Which is also a really interesting, first of all, mechanism of action, but also interesting in how it alters our ability to actually, again, alter that kind of calories in, calories out equation. Because if you're not able to absorb fat from the diet, like it's basically every gram you eat of fat, that's 9 calories per gram. Like if you are getting to a stage where you don't absorb those calories, but you still get to enjoy eating them in terms of like, again, mouthfeel, in terms of the foods that you eat, you inherently reduce calories because you're not able to absorb them, so orlistat is a drug that binds to fat in the intestines and, stops it being absorbed, which again, incredibly beneficial for reducing the amount of calories that you consume. Well, not even consume, the amount of calories that you actually take in and absorb into your actual body, not into your like digestive tract. However, again, it's not without its side effects. It does generally have the effect of giving people some relatively unpleasant side effects in terms of they have like, we'll call it more liquidy stools, because obviously there's more fat bound up in those actual stools themselves. And as a result, like they don't, like no one wants to basically have kind of like this semi-diarrhea all the time with the orlistat, So again, it's one of those things where I'm like, this is kind of cool, but there's also other side effects, not just of the like, oily stools. It's like, there are fat soluble vitamins that our body needs. And if you are not getting them in, like you are going to cause ill health. It's not like these are just, conditionally essential. It's like, no, your body needs vitamin A, like, so if you're not actually able to absorb it because you're not actually taking in any fat, like that's potentially an issue for you overall, do you have anything to say on the orlistat, Gary?
No, just again, just to reinforce the point that you said that the main, this is actually prescribed in Ireland a little bit more regularly than a lot of the other ones, I think. So orlistat is one that will come up fairly regularly if you look into obesity medications. But again, the tolerability can be limited by that fact of that you're basically just excreting extra fat in your feces, which isn't particularly nice. So
yeah, it's not, in my uneducated, stupid eyes, I'm like, this is just not one that I'd be like, this is just not that cool, But anyway, Gary, we also have the other one of the antidepressants, the naltrexone bupropion. What are your thoughts on that? Because it might seem a bit weird at the start to be like, oh, this is an antidepressant. Like, what are we talking about that in relation to obesity? But what are your thoughts here?
Yeah, so like naltrexone is an opioid receptor antagonist. So that's one that you'll actually see with in relation to substance use disorder. So people who are, trying to come off alcohol, for example, and opioids, you'll see naltrexone come up there, but also bupropion, which basically is involved in excuse me, involved in neurotransmitter reuptake again. So like there's multiple different effects, and generally that's what you see with a lot of centrally acting drugs. Like they can affect serotonergic, noradrenergic, dopaminergic signaling. So there's multiple different effects there. But yeah, again, this is sold as a combination. I'm not sure again of prescription rates in Ireland, but I know it's prescribed in the US. And again, acts centrally. So primarily what this is going to achieve is satiety or reduced food reward, and obviously then lead to reductions in caloric intake. Doesn't really have any effect on energy expenditure as far as I'm aware. Again, we're acting primarily here to reduce food intake.
Yeah, and also if you ever read the research, especially with a few different things that will be relevant for like health and fitness stuff, like low dose naltrexone is used for a few different things, but again, beyond the scope of this podcast. But yeah, look, we'll move on to the next one as we have actually just some actual interesting ones before we get on to the surgery stuff. One of the ones that you might not initially think, and it's obviously never going to actually be prescribed, even though it would actually be effective, is just, and again, this is also one that's like a natural one in case those people out there, they're like, oh, big pharma, they don't want to, I don't want to use big pharma. Okay, tapeworms, right? Like tapeworms. We just talked about orlistat in terms of being a fat blocker. How about just a fucking calorie blocker, right? Imagine you just had worms in your digestive tract that ate the calories instead of you, So phenomenal intervention for reducing your caloric intake. Just take a load of tapeworms, eat them, eat a load of tapeworm eggs. They used to sell them as a medical treatment. You could also get them in those fucking magazines. But take a load of tapeworm eggs, eat them. You now have easy fat loss because you could eat all the fuck you want, but you don't actually get to eat them because the tapeworms are eating them. And then you get fat loss, However, obviously, you have to get rid of those tapeworms at some stage, and nobody wants to pull tapeworms out their ass. And that's probably the biggest inhibiting factor for this being used. Obviously, again, we need calories, we need energy, we need nutrients. And if these tapeworms are eating all your nutrients, that's not beneficial. Not really anyway. So this is unlikely to be one that's, regularly uptaken. However, it is one of those ones that this is potentially an intervention. Like if you're looking at it from a perspective of like an alien looking down and going like, well, what potential ways could we solve this issue? This is one of those ways. But again, side effect profile, the fact that you have to fucking take tapeworms and nobody wants to basically say like, oh, I have a parasite, like, because that's what it is. It's unlikely to be used, And again, like nobody wants to pull tapeworms out their ass. I have never met someone that's like, that's actually what I do on my Friday night. Really get off to it. It's fucking phenomenal. It's just not happening. Do you have any thoughts on the use of tapeworms for the management of obesity, Gary?
Yeah, I mean, if you're going to stoop to that level, nah, sorry, just nah. Get your priorities straight.
Fair. Then another one, which is an interesting one, just to kind of finish out the interventions before we just touch on the surgery, because we're not going to touch on the surgery for too long, is like fecal transplants, right? And this is actually a really interesting one, but I actually don't think it is overly effective in humans. And there's a number of reasons for that, at least in my mind, at least. I don't know about the actual research. But like fecal transplants in terms of like your gut microbiome does a lot of stuff for you, right? We're not going to get into that because we'd be here all day with another podcast, right? And neither of us are gut microbiome experts, right? And effectively, there is a lot of research to show in mice, rats, rodentia, like rodents, that if you transplant the microbiome, so the gut bacteria of an obese mouse, or rather the other way around, of a normal weight mouse into an obese mouse, and vice versa then again, I suppose, they effectively change phenotype, right? And what I mean by that is like if you transplant the normal weight rat's gut microbiome into the obese rat's microbiome, into their gut, I mean, they effectively start becoming like a normal weight rat. So they were an obese rat, they got this fecal transplant, and then they became a normal weight rat, right? This again caused a huge flurry of research into this area, huge of like, oh, this is, we were able to solve this. All you have to do is take someone else's poop, someone healthy weight's poop, right? And like there are potential ways where we could argue that this is a beneficial intervention for certain issues. However, like in my mind, at least, I'm like, look, humans don't traditionally perform coprophagy, right? Like we don't traditionally eat shit, right? Rodents do, right? Like they actually do, right? And like dogs do it as well. Like you see dogs eat shit, right? So they are more receptive to, we'll call it fecal transplants, more receptive to altering their microbiome based on the environment, based on the shit that they eat, literally, because that is part of their we'll call it their genetic makeup. That is part of their how they interact with the environment. That's how they get signals about the environment. That's how they get beneficial bacteria, blah blah blah. That's not what humans do. Humans get beneficial bacteria in their gut from vaginal delivery and breastfeeding, and I suppose like kisses and stuff as well, especially from your mother. That's how we get our gut microbiome, right? And obviously, like that's not the whole way, like eating dirt as a kid, and that's why kids put every fucking thing into their mouth. They literally will pick up whatever is around them and put it into their mouth, and that is again them basically sampling the world. However, we don't practice coprophagy. Like your toddler is not going into the toilet and shoving shit into their mouth, right? Like even toddlers are like, oh, keep me away from poop, like they don't want to do that, right? So look, fecal transplants in my mind, like, and I think as well in the research, it's just not that effective. What are your thoughts, Gary?
Yeah, I would not recommend.
Have you not tried it?
Well, I have, which is why I said I would not recommend.
Oh, right. Yeah, nice. But yeah, look, this is just not something that I think is going to, first of all, get a lot of mainstream traction, or second of all, be an intervention that works effectively for people, both because the intervention itself, like you have to eat shit, but then also it just doesn't seem to be that effective. So, Gary, I'm going to let you talk about the bariatric surgery, or all these surgical interventions that we could potentially do if you are dealing with obesity. And if you wouldn't mind also just covering why you would potentially use a surgical intervention rather than like a lifestyle intervention, or potentially a pharmacological intervention, because I think that is also important for people to realize that, while it can seem like a, oh, get out of jail free card, like a kind of cop out of like, oh, just get surgery and you get weight loss. It's not really the case. Like obviously, like we're not talking necessarily about like what's that stuff called? Where you liposuction. Like that's not really all that beneficial, because again, lifestyle habits and stuff hasn't changed. Like you might actually get some weight loss from that, obviously, because they take fat out, but it's just not effective, right? No. But anyway, what are your thoughts, Gary?
Yeah, so I mean, when you're talking about indications for medication, you're basically looking at a BMI of greater than 30 without any comorbidities, or the presence of obesity associated comorbidities with a BMI of between 27 to less than 30, basically. So they're the types of indications you're looking at for medication. And basically for surgery, you're generally looking at a BMI that's much higher, so greater than 40 or greater than 35 with, again, those comorbidities associated with obesity. I basically like the lifestyle intervention is the mainstay of trying to intervene on obesity, but where that doesn't work, medication might be considered, and where that doesn't work, surgery might be considered. And again, this is totally going to vary depending on patient preference, whether or not a patient is going to be appropriate for surgery. Like, does a person already have advanced heart failure or something that would contraindicate them from being eligible for surgery? Are they public? Are they private, etc.? All these things are going to vary or influence the decision making there. But in terms of surgical intervention, effectively what you're trying to achieve is basically rewiring the gastrointestinal system, so to speak, in such a way that the person is going to be fuller much quicker, and as a result is going to be eating far less calories and is going to lose far more weight than they would be able to if they were just engaging in a behavioral intervention. And there's a couple of different approaches. The two primary surgeries that you'll hear of will be a Roux-en-Y gastric bypass or sleeve gastrectomy. And effectively, both of these involve reconfiguring the stomach in some way, either through just a bypass with a small little pouch, or basically turning the stomach, removing most of it and then turning it into effectively no more than just a little tube. And both of these things effectively reduce the volume available for food to enter within the so-called stomach. And then as a result, the person is going to be tolerant of far less food. They're not going to want to eat as much. They're going to eat less calories. And as a result, they're going to lose a lot more weight. So is it effective? Yes. But with any surgery, you're always dealing with, again, much like drugs have side effects, surgeries obviously carry risks, whether that be related to wound site infection, complications from the surgery or the anesthesia, etc. So there's always risks there. So yeah, they're basically the mainstay of the surgical options. There are other options that are a little bit more complex, but they're the two primary ones. And again, it's not necessarily a shortcut as such, because the person is engaging in a surgical intervention, which, there's risk associated with that. And ultimately, again, it still ends up coming down to calories in, calories out, because fundamentally what you're changing there is basically the calories inside of things primarily.
Yeah, and this is also one of those things as well where, again, it comes back to that initial equation that we've talked about, but then also you get side effects from this, not just even the surgery. Let's say the surgery all goes well, everything fantastic, you heal up. Like, there's still downstream effects where you are eating less calories now. Yeah, okay, cool. But you generally have lower absorption of different minerals, vitamins and stuff like that, because you're not actually able to eat enough food to, first of all, get the stuff that you want. But then also, if we're fucking around effectively with the plumbing, it's like you potentially aren't able to, it's not spending enough time where it needs to get absorbed and stuff, right? So there are some issues with that. Again, look, it's outside of our wheelhouse because it's something you need to discuss with your doctor.
Yes.
And ideally, and I think it is the case, there would be some intervention with some sort of registered dietitian thereafter, so that, again, you're overcoming any of those issues with malabsorption or fucking whatever, right? So that kind of concludes the pharmacological and alternative therapies for obesity. Before we wrap this up, Gary, do you have anything else to say with regards to any of that? Anything at all?
No, my pro-obesogenic dinner is waiting for me on the table, so I'll be leaving urgently.
Fantastic. And your girlfriend's about to beat you up.
Absolutely, I'm dead. You won't hear from me next week. I won't be on the podcast.
Nice. But yeah, look, that was hopefully interesting. As we said at the start, two of us are idiots. This is not medical advice. Take from it what you will. Some of these things potentially maybe you think is interesting enough to go and look into. Maybe, again, it gives you that perspective that, okay, this is more complex than, when people make these caricatures of like, calorie counting doesn't work, there's more to it. I'm like, yeah, of course. Like, here you go. Here's the more to it. There's hundreds, thousands of drugs that work through different mechanisms, and they all of them lead back to that same equation of managing that calories in, calories out, right? In some regard, some of them work on the brain, some of them work on the nervous system, I suppose. Some of them work on, the actual stomach or the actual plumbing, we'll say. They all work through different mechanisms, but they all alter that equation in some regard. So yes, 100%, there is more to it than calories in, calories out. However, that doesn't discount the fact that it all comes back to calories in, calories out. But anyway, look, guys, that kind of concludes the obesity series. I hope you enjoyed. I hope you listened to them all with, fervor and attention. And if you do have any questions, look, we have a Facebook group. Join it, ask questions there, and I'll let Gary conclude the podcast.
Yep. that's it. Follow us if you'd like. Triage Method, Skinny Guys, The Real Paddy Farrell, and Brian O'Hangasa on our respective social media accounts. Of course, we have coaching spaces available if you do need to get help with your training, nutrition, or otherwise. Do get in touch, and we're always putting out new content. You guys know that. Subscribe to the newsletter, join the Facebook group, follow the social media, and if you're a coach looking for your own education, do join the Coach's Corner, and that's everything you need.
Fantastic. And we will see you next week, guys.